Hi everyone, I'm Dr. Izadi from Pristine Wellness Center. In this short video, I just want to give you an idea, a quick glance on hormone replacement therapy for men, what is andropause, what the symptoms are, how we diagnose it, and what are the options to treat that. So some of you asked me what these abbreviations mean. Well, MD is medical doctor, fellow of American Academy of Pediatrics, American Board of Anti-Aging and Regenerative Medicine, American Board of Integrative Holistic Medicine, American Board of Integrative Medicine, licensed acupuncturist, and licensed athletic trainer. So these are my credentials, and I had extensive training in integrative medicine and specifically hormone replacement therapy in men and women. A lot of people think when we talk about andropause, we talk about lack of sex drive, erectile dysfunction, and that's what we call andropause. But the reality is that andropause and testosterone deficiency causes a lot more symptoms than just decreased sex drive. So the symptoms of andropause, testosterone starts dropping in mid-30s and drops on average 1.6% every year. Hypogonadism, meaning low testosterone, is diagnosed in 30% of men in their 40s to 70s. Surprisingly, recently, because I checked testosterone on all my male patients, I've seen very low testosterone in even 25-year-olds. And I explained to you why that happens, because we have a lot of endocrine disruptors in the environment and we have daily exposure to. So the signs and symptoms of low testosterone are fatigue. You just feel like you don't have the same energy that you had in the past. Decreased libido, erectile dysfunction, depression, irritability, decreased sense of well-being. It's very interesting. One of the symptoms is avoiding high-risk activities like skydiving, or even skiing. Some of my patients told me that they would not enjoy skiing anymore because they feel the risk of falling, breaking bones, and that can be a sign of testosterone deficiency as well. So we need testosterone to build muscle and bone, and as the result of low testosterone, we have decreased muscle mass and increased body fat, especially visceral fat, which is the fat around the internal organs and omentum inside the belly. And as I said, we need testosterone for bone density, and we start losing bones when we have low testosterone. I say we because men and women both need testosterone for all these things, but the level of testosterone, of course, is lower in women, but both genders need testosterone for all of these, actually. And memory loss, lack of focus, brain fog, lack of high quality sleep, insomnia, and also there is increased risk of cardiovascular disease, diabetes, Alzheimer, and other issues that come with aging. And low testosterone can increase the risk. So men, like women, have all these hormones: testosterone, pregnenolone, which is the precursor of sex hormones, androstenedione. These two are precursors. Men also have progesterone and two types of estrogen, estradiol and estriol, and dihydrotestosterone. Dihydrotestosterone is the hormone in men causing hair loss and enlargement of prostate gland. And we use finasteride, dutasteride, or saw palmetto supplement to block the enzyme 5-alpha reductase that converts testosterone to dihydrotestosterone. DHEA, dehydroepiandrosterone, is also another hormone. They call it longevity hormone. And again, men and women both need the DHEA, progesterone, estrogen. In the normal range is, of course, different in men compared with women. So when we want to start hormone replacement therapy, there are some labs that we check. Checking the testosterone hormone level in men younger than 40, it's better to be done in the morning because it's higher in the morning. But if the patient is over 40, it really doesn't matter what time of the day. So there are some routine labs, the complete blood count, comprehensive metabolic panel. Complete blood count is important to know that the patient doesn't have too many red blood cells, because one of the side effects of testosterone is also increasing the number of red blood cells. And if we have too many red blood cells, then there is increased risk of clot formation. Comprehensive metabolic panel to check for kidney and liver function, total and free testosterone, sex hormone binding globulin, and all other hormones, testosterone, progesterone, estradiol, DHEA, dehydrotestosterone, PSA, prostate-specific antigen, FSH and LH, which are the hormones in the brain stimulating testicles to produce testosterone, and also sperm, and prolactin. So testosterone drops with age. Also, stress can decrease the level of testosterone. Insulin resistance and diabetes can decrease the level of testosterone. The decreased level of testosterone can also increase the risk of diabetes. And again, endocrine disruptors. I will have another video just describing endocrine disruptors, what they are, how we can avoid them, because those are one of the major causes of drop in testosterone. So total testosterone is combination of free testosterone, meaning that testosterone that is not attached to any protein and it's free to go to cells and start working, and also testosterone that is attached to albumin, which is the main protein in the blood, and this attachment is weak, and once this complex gets next to the cells, if the cell needs testosterone, albumin releases testosterone to start working. And the third one is testosterone that is attached to sex hormone binding globulin. This sex hormone binding globulin has very tight attachment to the testosterone to the point that it doesn't release testosterone to start working. So essentially, whatever testosterone is attached to this protein is non-functional. And sex hormone binding globulin increases in level as we age, and there are some other factors increasing sex hormone binding globulin. In another short video I explain that. So we essentially measure the bioavailable testosterone, meaning the part of testosterone that is actually functional, which is free testosterone and the testosterone attached to albumin. If you Google bioavailable testosterone, you see the formula and you can actually put the numbers and measure your own bioavailable testosterone. And this is the same for men and women. And testosterone hormone replacement therapy in younger men who still want to have kids, or they don't want to shrink the testicles, we don't give them testosterone hormone, because the hormone can shrink the testicles, suppress the function, and whoever who's on testosterone hormone has to continue that as long as they need testosterone, and the testicles will not start producing testosterone again. So in younger men, we prefer to stimulate production of testosterone from testicles by increasing the hormones from the brain, such as FSH, LH, clomiphene, N-clomiphene, and HCG. These are hormones that can stimulate testicles to produce more testosterone. In older patients who don't want to have kids or okay with shrinkage of testicles, we can use testosterone hormone directly. Testosterone can be prescribed intramuscular, subcutaneous injection, pellet, or a topical cream and nasal spray, as well as oral. So the pellet, this is a good way for doctors to make money when they do hormone replacement therapy, but it's not the best way to give people hormone replacement therapy, because once you put the pellet, it's there, the same dose, for 3 to 4 months. So you cannot adjust the dose. You cannot stop it if, God forbid, something happens, you're diagnosed with prostate cancer or anything that, congestive heart failure, anything that needs to stop testosterone. We cannot do that if you have a pellet. It's there until it absorbs. And the topical cream, compared with other forms, can increase dihydrotestosterone more. There are some oral form of testosterone, but they are very expensive. Oral form can cause high blood pressure, damage the liver, cause hepatocellular carcinoma in the liver, and it has also adverse effect on lipid panel. Unlike other forms of testosterone that can actually help to decrease the level of lipids in the blood. There are newer formulation for oral, but they can absorb through lymphatic and bypass the liver, but they are more expensive. And nasal spray has less testicular atrophy, but not the best way to have a steady level of testosterone in your system. The other hormones in men, as I mentioned, progesterone. If there is very low progesterone, we might need to give men progesterone, dihydroepiandrosterone. Progesterone especially helps with sleep because it increases the level of GABA, and we can use it as a cream, oral, if we want to increase the GABA. And progesterone decreases the activity of 5-alpha reductase and also stimulates p53. So this one increases the activity of p53, can decrease the risk of cancer. And 5-alpha reductase, when you decrease the activity of this enzyme, you drop the level of dihydrotestosterone, which is the cause of hair loss and prostate hypertrophy. And if I check your level and your estradiol is high, we may start medications like anastrozole, letrozole, or quercetin or chrysin. These are supplements, and resveratrol, zinc, and progesterone to decrease the level of estradiol. So these are, supplements, zinc, resveratrol, chrysin, and quercetin to drop the level. But again, if it's too high, we give you medication. But the level should not go below 10 because men need some estradiol to keep the bone density and not to lose too much bone. And high estradiol can cause gynecomastia, enlargement of the breast, decreased sex drive. It doubles the risk of a stroke and increases the risk of cardiovascular disease, insulin resistance, rheumatoid arthritis, benign prostate hypertrophy, and prostate cancer. So that's why it's important to check the level of estradiol and correct it if it's too high. And the evidence regarding testosterone hormone replacement therapy and cardiovascular disease. In the past, there were a lot of discussions that, testosterone hormone replacement therapy can increase the risk of cardiovascular disease, but in 2014, at Mayo Clinic, Dr. Morgenthaler with his colleagues reviewed every document ever reported regarding testosterone hormone replacement therapy. And based on their report, they checked all the literature from 1940 to 2014. And they found over 200 articles. Only 4 articles showed increased risk of cardiovascular disease. And in these 4 articles, if you review those research, they have some bias. They are mainly older people, fat, or have diabetes. They have many other risk factors for cardiovascular disease, and it's not accurate to increase the risk of cardiovascular disease connected to the testosterone hormone replacement therapy. And there is a recent study called TRAVERSE study. TRAVERSE is abbreviation for testosterone replacement therapy for assessment of long-term vascular event and efficacy response in hypogonadal men. This one was designed in 2017. It was a prospective randomized double-controlled trial with half of patients on placebo, and it was multi-center study. They had over 5,000 men from 45 to 80 years old. At the end of this study, after 5 years, there were only 2,000 men there, 1,000 in each group, placebo and testosterone hormone replacement therapy. But that's still a lot of patients to make any reasonable conclusion. So they had to follow up, and this TRAVERSE study was published in New England Journal of Medicine in 2023. And the patients who had testosterone less than 300 started testosterone gel or placebo. And as you might know, this type of a study that you use placebo in half of the patients and real medication in other half is the best form of a study and the most accurate one. So the result of TRAVERSE study was that testosterone is not associated with increased risk of cardiovascular disease despite a higher incidence of pulmonary embolism. So if you look at the incidence rate, pulmonary embolism was 0.9 in testosterone group and 0.5 in placebo group. Not much difference. Acute renal failure, 2.3 in testosterone, 1.5 in placebo group. Atrial fibrillation, 3.5% in testosterone group, 2.4 in placebo group. So it's hard to make the conclusion that testosterone was the reason for these issues, pulmonary embolism, atrial fibrillation, or acute renal failure, acute renal injury, sorry. So they titrated the testosterone gel to keep the level from 350 to 750 and hematocrit below 54%. In my patients, I always prefer to keep the hematocrit below 50% to make sure there is no increased risk of clot formation. And the normal testosterone level in every patient is different. And if we can check the level when the patients are young and asymptomatic, then we can use that level in future for the treatment. But the normal level is from 350. I've seen patients with the level of 1200 as well. And again, at the end, there were only 2,000 people left to finish the 5 years follow-up. Only 1,000 in each group finished the study, and half of them were over 65 and mostly obese. So considering all these risk factors, we had very, very good outcome in testosterone group. The same study showed significant improvement in sexual function and no increased risk of prostate cancer. So again, testosterone can increase sex drive and decrease erectile dysfunction. There are some supplements to increase testosterone level. You don't need prescription for that. You can try it before you start any medication. If your testosterone level is low, there's Ayurvedic Shitaji, ashwagandha, which is an adaptogen, Tonkat Ali. This is a supplement you can get online. It's called Testojack. I would start with 300 milligram if you want to do it. There are also other things that can help vitamin D. The optimal level of vitamin D is 60 to 80. Quercetin, zinc, chrysin, and sleep. A good night's sleep is very important to keep the level of hormones steady. Alcohol is bad, and it can increase the risk of hypogonadism. And xenoestrogens are the environmental endocrine disruptors that can drop the level of testosterone. So we need to avoid alcohol, xenoestrogens, endocrine disruptors, and have a good night's sleep. And then what do we monitor when the patient is on testosterone hormone replacement therapy? At the beginning, we check the labs at 6 weeks to 3 months after we started, and then every 6 months. The labs, again, these are the labs that we recheck in follow-ups. And again, the optimal level of testosterone depends on the age. And when I see you in my office, we measure bioavailable testosterone and see what is the level for your age. And there are some contraindications for testosterone hormone replacement therapy, such as active prostate cancer, breast cancer. Yes, men can have breast cancer, and actually over 2,000 men every year in the US get breast cancer. Prostate nodule or induration, unexplained increased PSA, that's why we check the PSA on every follow-up. Hematocrit above 50 is called polycythemia, unstable congestive heart failure, and severe untreated sleep apnea. So if you have a sleep apnea, first you need to treat that by either using CPAP or laser, photolaser, night laser, and then we can start hormone replacement therapy. So again, this was a very quick overview of hormone replacement therapy in men. I hope it helps to give you an idea what it is and what your options are. And if you have any question, you can always contact me through email. And I hope to see you soon.